a third-year ER resident in New Jersey in the US. Shelley's one of my colleagues. I'm going to be teaching the basics of an initial trauma assessment today. I have to say, like in every PowerPoint, I have no financial or other conflicts of interest to report, just that Shelley's my friend. And just as a disclaimer, this is really intended to be Trauma 101. So people do entire fellowships in trauma. Even the actual Advanced Trauma Life Support certification class is actually a 2-day course. So our goal here was kind of inspired by a question that was asked Shelley before she started MEDIPATH this year, and it was, how do you not get flustered during a trauma resuscitation? So the answer to that is really to use a stepwise approach, and I want to teach everyone a stepwise approach today. Addressing trauma is a major component of emergency medicine, and we're asked to quickly evaluate these patients, address a full inventory of injuries. So having a systematic approach is really the best way to minimize your chance of missing any injuries. Okay, so I'm curious to see how much experience do you guys have with trauma as a medical student. I know these were patients that we were told not to see or to steer clear of because they tend to be more higher acuity. But I'm just curious how much experience you guys have. So Jelly's going to do a poll everywhere and find out.
All right, guys. So you guys should have the link. I'll type it in the chat box as well, just in case you don't. And yeah, so, oh, you're getting answers already. Okay, so you guys see it up in the chat earlier. Oh, you have one person lives and breathes and lives for trauma.
Nice.
But a lot of them, yeah, similar to us, that they haven't had much experience with traumas, like when they were a student. Now we have a lot.
Yeah. 53%. Okay, good. I'm glad most of you haven't had a ton of experience with it because, like I said, my PowerPoint really addresses the basics. So cool. Okay, so trauma really starts pre-arrival or pre-hospital. Before you start, just, maybe it's obvious, but all providers should really, in the trauma, wear full PPE. Even before the age of COVID, trauma centers or true trauma centers and the classic trauma surgeons recommended gowns, gloves, face mask, and face shield. Usually we don't know anything about our trauma patients and their state of health, and traumatic injuries can get very bloody, so we really have to protect ourselves and wear all of this equipment. In addition, if you are planning to get portable x-rays, you should wear a lead gown to protect you from the x-rays. And obviously in the age of COVID, I would recommend wearing an N95 before assessing any patient. Okay, next slide. So before your trauma patient arrives, you will often get a report from pre-hospital personnel. In the US, we have a system of paramedics and emergency medical services, and we get calls on phones of any critical patients arriving via paramedics. In things you want to know from the paramedics include the vital signs that they assess before the patient arrived to the hospital, the Glasgow Coma score, and the mechanism of the injury. You don't want to be too detailed on the phone and hold them up from caring for the patient or getting the patient to you, but asking some key questions might be your only opportunity to prepare. And you can use even just this basic information to prepare for the anticipated interventions and your needs for staff. You can usually triage even just based on initial report of, is this blunt versus penetrating trauma? What's the mechanism of the collision? Were there fatalities on the scene? And if they fell, from what height did they fall? And a set of vital signs. Next slide. Okay, so this is, did we turn this one into a question?
Yes, I did. It's next slide.
Okay, great. So this is going to be an example of a decision you might make just based on a pre-hospital report. So, a 28-year-old male unrestrained driver is intoxicated intoxicated. He is T-boned by another car. There's a fatality on the scene. His GCS is 14, blood pressure 90/60, heart rate 120, oxygen is 90% on 4 liters of supplemental oxygen. And the question is, would you want this to be full trauma, meaning having all of your trauma personnel available to help, mobilizing all your resources, making sure the patient goes to a trauma center with a trauma surgeon, or do you think this patient can be triaged as a lower priority? Just based on this information, you should be able to determine that. Okay, so
looks pretty unanimous.
You. Yeah, it looks pretty unanimous. So the concerning factors in this story are the patient's drunk, there was a fatality on the scene, he was unrestrained, the blood pressure is kind of borderline, the heart rate is high, he's requiring supplemental oxygen, and as you can see, a lot of the decisions like this are kind of just common sense. We haven't learned any specifics of trauma yet, and yet we were able to discern this patient needs some special attention. So given that report, who and what would you want in your trauma bay? We determined that they need special attention, but who are you going to call ahead of time to say, I need you in the room, we have a critical patient coming in, what are some things that you need in a trauma resuscitation bay? Some things or some people. So you can just type in a response, like for example, you might type in trauma nurse. Oh, that's great. An anesthesiologist, a surgeon, a radiologist, right? Ideally, you'd have the radiologist and surgeon on call at your trauma center. You definitely need a respiratory therapist. This patient sounds like he may or may not need to be intubated. Anyone else? We can't forget, like our nurses, our technicians. What's some equipment you might need? Right? You definitely need some uncrossed blood. Good. Definitely might need a central line with hypotensive patient. Okay, these are all really good answers. All right, so you will need, like all of you mentioned, either an anesthesiologist for a difficult airway. In the emergency room, oftentimes that's the ER physician. You need a setup for an intubation and some backup equipment anticipating a difficult intubation because of the traumatic injury. You may need some chest tube equipment. They said the patient was hypoxic and he had a traumatic injury. You need central lines, large bore catheters, uncrossed blood. That was a really good point someone made. The trauma surgeon, nurses, and technicians. Next slide. Okay, so let's say you get pre-hospital information about a few other patients. Which one of these patients do you anticipate need to be intubated as soon as they get to your ER? Let's say 68-year-old male fell down, he's on blood thinners, unresponsive. A 25-year-old male has a stab wound to the chest and has unequal breath sounds. A 36-year-old female with an open femur fracture, she's screaming in pain. Okay, looks like we're split between A and B. Okay. So there's really no right answer here, although the most correct answer is A. The unresponsive patient would most immediately need airway protection, and because he's unresponsive and he's on a blood thinner. It sounds like he had a head injury and likely has a brain bleed, and therefore, we'll talk about this later, but in trauma, a patient with a GCS or Glasgow coma score less than 8 generally needs to be intubated. B was a good answer too. However, oftentimes in patients with unequal breath sounds and likely pneumothorax, intubating or providing positive pressure can make a pneumothorax worse. So although they might ultimately need to be intubated, likely first they would need a chest tube, and you'd set that up and then assess what their need for a supplemental airway is. And technically C, you might need that to intubate that patient too, but not immediately. Patient with open femur fracture needs to have that fracture reduced. And sometimes we intubate just for pain control. But the point of this was really to conclude that you have the ability to determine what you need before a patient even arrives in your ER. Okay, so once your patient does arrive, it's important to complete the emergency medical service handoff. The handoff is literally the handoff of the patient from the pre-hospital personnel to your staff. It's really important that you have silence in the room when you get report from these personnel, because as soon as they give you the patient, they're going to leave and go up someone else. So it's your job to be the leader in the room. Sometimes it's as easy as saying, medics have arrived, let's all listen for a report. You have everyone in the room listen, because you don't want people interrupting and saying, oh, what did you say? What about this? You should listen closely, ask whatever you need to ask, because this might be your only chance at a first-hand history. And meanwhile, the first action by the installation staff should be to start placing the patient on a monitor and obtaining vital signs. Next slide. So now we're going to discuss the actual trauma survey. It starts with the primary survey. The goal of the primary survey is to find and address any immediate life threats. The typical approach we use is an ABCDE mnemonic, which stands for airway, breathing, circulation, disability, and exposure. Although often we teach this as dictating the priority of assessment, meaning airway first and breathing before circulation, all components should be assessed really in parallel. In reality, we have a lot of help in our trauma bays, and we do this kind of all in tandem. But honestly, you can really briefly assess ABCs of any patient by walking to a room, identifying yourself, asking the patient's name, and asking what happened. An appropriate response to this question suggests that there's no major airway compromise. If they're able to speak clearly, it suggests their breathing is not compromised. If they're able to generate enough air to permit speech, and there's no major decrease in level of consciousness if the patient's alert enough to describe what happened and what their name is. So even to just walk in and say, hi, my name is Dr. X, what's your name, what happened? And if you don't get an appropriate response to that, you have to start addressing each component in more detail. So that starts with the airway. The airway, that we use the mnemonic ABCDE, but each letter also has a part tagged onto it, which is the part that is what we're addressing in that survey. So airway maintenance also includes cervical spine protection. You first want to look for any potential obstructions to the airway, like facial injuries, any blood or vomit in the airway. You should suction and try to stop the patient from vomiting, but sometimes you need to intubate if you're afraid they're going to aspirate. You have to quickly assess their mental status and determine whether they're able to clear their secretions and keep their tongue from obstructing the airway. A patient who's completely obtunded would not be protecting their airway and might need a definitive airway. And finally, you don't want to move their cervical spine. You want to place them in an aspen collar or a cervical protective collar until the cervical spine can be further assessed. So we have another question here regarding the airway. A 22-year-old female was drinking and driving. She crashed into a telephone pole and hit her head. 10 minutes after arrival, she begins vomiting profusely in your ER. What are your next actions? Are you going to sit the patient up? Are you going to suction, maintain the cervical spine, and prepare to intubate the patient? Should you start ventilating the patient with a bag valve mask? Or D, should you start CPR? So once again, this is a 22-year-old female. She's drinking and driving, crashed into a telephone pole and hit her head, and now she's vomiting profusely in your ear. Like everyone's leaning towards B. We have some A's in there. I'm glad no one's starting CPR yet. Okay, so the answer is B. This patient's not protecting her airway, but you still have to maintain cervical spine precautions because she could still have a C-spine injury in addition to the head injury that's causing her to vomit. One person would hold the C-spine while others help to turn her to the side, and kind of like a log roll and suction. With profuse vomiting and a head injury, you're concerned for any intracranial injury, and you might need to quickly intubate this patient to prevent aspiration. A was just incorrect because if you sit the patient up, you're technically moving her cervical spine, and likely she's going to keep vomiting, so it's not really a definitive solution to what's going on. Okay, and obviously D was incorrect because she still had pulses. Okay, this is, I apologize for the wordiness here, but this is another question about airway. A 55-year-old construction worker presents to the ED after a fall from 20 feet while at work. Per EMS, the patient was confused when they found him with a large hematoma over the right temporal area. There's swelling of the right maxilla and deformities to the right shoulder and knee. On arrival, his GCS score is 8 with a blood pressure of 162/96, heart rate 72 beats per minute, and oxygen saturation of 100% on a non-rebreather mask. What are your next steps? Attempt rapid sequence intubation with inline cervical immobilization. B, get cervical spine radiographs prior to establishing a definitive airway since the patient's oxygen saturation is 100%. C, continue oxygenation via non-rebreather mask and immediately obtain a CT scan of the brain followed by neurosurgical consultation. So once again, this was a 55-year-old male. He hit his head. His GCS is 8. Blood pressure is stable. He's on a non-rebreather mask. He has some swelling on his face, swelling of his head. He has some deformities of his shoulder. Okay, looks like we're split between A and C. Okay, so the correct answer here is actually A. You want to intubate this patient while maintaining inline cervical spine immobilization. The reason being is his Glasgow coma scale is 8, and in trauma, we say trauma patients with a GCS less than or equal to 8 require immediate airway management. It's suspected that even a single episode of hypoxia in a patient with a severe head trauma like this can lead to a poor prognosis. I know a lot of people said C, and while it is correct that his oxygen saturation is okay, he's not protecting his airway because of his mental status. And oxygen saturation, although while it shows how well he's oxygenating, it doesn't show how much at risk he is for aspirating. You wouldn't want to take the patient to the CAT scanner with a GCS this low and with a suspected head injury, with a suspected brain bleed. Trust me, it's happened before, and they go to the CT scanner, they'll have a seizure, the CT scanner, now you're having a bigger issue. In trauma, we like to see CT scan is where patients go to die. Until you've stabilized the patient, it's really not prudent to take them to the CAT scanner. And this patient, because of his Glasgow coma scale, would not be safe to go yet. Okay, so we're still on A of our primary survey, and we're going to talk about reasons to intubate a patient. Really, this is an advanced skill knowing when to intubate someone, but it's important to know at least the book reasons or the main reasons that you would need to do obtain an definitive airway. So you can split that into need for airway protection and need for ventilation or oxygenation. Airway protection would be needed in a patient with severe maxillofacial fractures. If they have any risk for obstruction, like a large neck hematoma, if they have an abnormal voice suggesting a laryngeal or tracheal injury, if they're at risk for aspiration, like their patient before who's profusely vomiting, or if they have blood coming from the airway, or if they're unconscious or have that GCS less than or equal to 8. If they might be protecting the airway but need help with ventilation or oxygenation. So they might have inadequate respiratory efforts. If they're tachypnic, they're hypoxic. If you have end tidal setup and they're hypocarbonic, or they're bradypnic. If they have a severe closed head injury, and in some instances you do hyperventilate those patients. If there's massive blood loss and they need a lot of volume resuscitations, and if they're apneic or they're paralyzed, then certainly you would need to intubate that patient. And so if you decide none of these things are an issue when assessing the airway, you'll move on to B, breathing. At that point, you can still make a determination that they need to be intubated or more airway support. But let's move on to B and talk about what you assess in breathing. So in B, we look at breathing and ventilation. You want to inspect and palpate the chest wall to look for any injury. Look at the position of the trachea, look for tracheal deviation, look for JVD. Inspect the patient's workup breathing. Are they breathing fast? Are they breathing very slowly? You might need someone to hold the cervical collar while you remove you might need someone to hold the C-spine while you remove the cervical collar and look for any injury to the neck. You should listen to breath sounds bilaterally. If you don't have breath sounds, on one side and the patient's hypoxic, at that point, you may need to insert a chest tube or perform a needle decompression before moving on to the rest of your survey, because a patient with a pneumothorax can quickly decompensate. And in many instances, you would put in a chest tube or do a needle decompression before you've even obtained any imaging. If you really are not hearing breath sounds, there's a chest wall injury and there's obviously a reason for pneumothorax there. At this point, you want to make sure that the patient's on continuous oxygen monitoring. You assess the O2 saturation. You can attach end tidal or just observe the patient's respiration to see if they need any assistance. This GIF here shows what's called a flail chest. A flail chest occurs due to segmental rib fractures in 2 or more locations of the same rib. So if you have a few adjacent ribs that have multiple fractures, you have a section that's kind of free floating and it's no longer attached to the thorax. It's commonly associated with respiratory failure and pulmonary contusion. As you can see in this image, there's already a chest tube on that side. Not necessarily associated with pneumothorax, but there's a high likelihood. So now we have a question about breathing. A 40-year-old male presents to your ER via ambulance with altered mental status and visible chest wall bruising after a ceiling collapsed on him. The patient could not get out from under the debris until EMS arrived 20 minutes later. The blood pressure is 100/55, heart rate's 115, respiratory rate's 24, oxygen saturation's 90% on room air. GCS is 9. You do not hear breath sounds on the left. What are your next steps? You get a CT scan of the head, neck, chest, abdomen, and pelvis. You do a diagnostic peritoneal lavage, or see if you do a tube thoracostomy or a chest tube. Okay, great. So this seems pretty unanimous after our discussion. The answer is C. The patient likely has a large pneumothorax and will need a chest tube to allow for lung re-expansion. If the patient has, like I said, obvious chest injury, low O2 sat, diminished breath sounds, you don't have to wait for a chest x-ray before putting in a chest tube in the setting of trauma. All the other 2 answers were incorrect. We barely ever do DPL, diagnostic peritoneal lavage, anymore. You would not send this patient to CAT scanner without stabilizing B assessment in their primary survey, and the answer was C. Okay, now we can move on to circulation. So stands for circulation and hemorrhage control. Remember, the mnemonic ABCDs are there to help, but always remember the second component, which is of the mnemonic, which is the intervention. You want to make sure that you have a set of vital signs on every one of your trauma patients, and C is your opportunity to take pause and make sure that you have those vital signs. Believe it or not, sometimes so much will be happening, you'll realize that no one has even taken a blood pressure. Next, you want to make sure that the patient has peripheral pulses, radial pulses, DP and PT pulses. You need to next make sure that there's no signs of external bleeding, and if there is, you want to stop with direct pressure or a tourniquet. And finally, if you do have abnormal vital signs, you have a low blood pressure or an elevated heart rate suggestive that the patient is losing blood somewhere, you want to consider starting IV fluids and also perhaps starting blood. We order a type and screen on every one of our trauma patients in the anticipation that they will ultimately need a lot of blood, but in this case, you might even give them uncrossed blood if they're really hypotensive and have an obvious source of bleeding. If you can't find external bleeding, but the patient is hypotensive, check the pelvis for stability and place a pelvic binder. Patients can bleed internally due to pelvic injuries and pelvic fractures. Finally, you might do something called an EFAST exam on every trauma patient to look for free fluid in the abdomen. EFAST is a type of ultrasound examination that looks for free fluid in the major areas of bleeding. EFAST stands for Extended Focused Assessment with Sonography for Trauma. So this is a great tool in trauma. It's an ultrasound, and we're going to talk a little bit more about that. Oh, the 5 major areas a patient can exsanguinate are the chest, the abdomen, pelvis, the retroperitoneum, long bone, and on the street, meaning they bled before they even got to your ER, and then EMS controlled the bleeding, but now they're still hypotensive from it. Also of note, in pediatric patients, they can have significant blood loss just from a head injury, from a scalp laceration, just because they're highly vascularized and they have lower blood volumes. In adults, it's less likely that someone becomes hypotensive from a head injury or bleeds out into their brain, but it is possible if there's an arterial bleed in the scalp. Okay, we can move on to the next slide. So, it does take a lot of detail to understand a FAST exam, understand how the ultrasound works. Really, it's a hands-on experience. This is really just a brief overview of what you're looking for in an EFAST exam during your primary trauma assessment. But definitely, if you have more questions about this, I can answer it later. The areas you look in the EFAST exam are the right upper quadrant, the left upper quadrant of the abdomen, the subxiphoid space where you look at the heart, the suprapubic space where you look at the bladder, and then you look at the right and left chest to assess for pneumothorax using your ultrasound. With the FAST exam, you can identify as little as 100 mLs of free fluid. But if you do this fast and there's no bleeding and they're still very hypotensive, you should also put the patient in a pelvic binder, like I said before, because they could have injury in the pelvis that you might not detect. And just of note, the EFAST exam should be done during the circulation portion of your primary survey, especially if they're hypotensive. In some cases, if they're not hypotensive and they're pretty stable and it's too obstructive to be in there with an ultrasound, you can wait till the end of your primary survey to do the EFAST exam. But any abnormal vital sign, especially hypotension or tachycardia, you should do this during the circulation portion to assess for internal bleeding. Okay, so this is just some brief imaging to show you what an EFAST looks like. Hopefully you'll get some hands-on training with this in the future because it really is the standard of care for emergency physicians to use ultrasound. The first view I always look at is the right upper quadrant. There you're assessing Morrison's pouch, which is the hepatorenal space in the right upper quadrant, and you're looking for any free fluid, which would look like kind of more a dark hypoechoic area in between the lines in the right upper quadrant. That's image 3 on this. Does my mouse work on this? This one. And then you check the left upper quadrant for fluid in the splenorenal space. It's over here, so it would be between the spleen and the kidney there. Then you will check the bladder pelvis in 2 views, the transverse and longitudinal views, to look for any free fluid around there. In women, you'll see the uterus there, and you might see free fluid. Sometimes there's a physiologic amount of free fluid, but you're really looking for any large amounts. That would explain hypotension. Finally, you can check the heart in a subxiphoid view and just make sure that there's no large pericardial effusion, because large pericardial effusion can cause hypotension as well. And the EFAST is called an extended fast because the last 2 views, which are the hearts, which is the bilateral lung, and you can see in the lungs if there is lung sliding. There's appropriate lung sliding, which looks like what you see at the rib here. You have the pleura here, and this pleura kind of has a shimmering look on the ultrasound. It's a dynamic image. That lung sliding suggests that the lung is moving and that the patient is breathing and aerating that lung, and there's no pneumothorax. In fact, ultrasound is more sensitive than a chest x-ray for detecting pneumothorax, so it's important to include this in your EFAST exam. Okay, we can move to the next slide. Next slide, please. Thank you. So you do your FAST exam and your patient's stable. You don't see any free fluid, so you have a stable patient, negative FAST exam. You continue to observe them, continue with your primary survey, and you can reassess later about any need for further imaging. A stable patient with a positive EFAST, let's say you find a little bit of fluid in the right upper quadrant, they should get an emergent CT scan of that suspicious area to further evaluate. And that CT scan should have it after you finish your primary survey. Okay, next slide. If your patient is unstable and you do a FAST exam, you look in the abdomen, you look at the chest, it's negative, what you can do is repeat the FAST exam, maybe at the end of your survey in 15-20 minutes, and see if you find fluid there. The FAST exam becomes more sensitive with repeated use, or you can try to stabilize your patient, get them straight to the CT scanner, and see if there's any bleeding that was not detected on your FAST exam. Also, patients can be unstable from head injuries and things that you're not looking for on your FAST exam. So your suspicion that it's intraperitoneal should be lower. If your patient is unstable and you have a positive FAST exam, meaning they have low blood pressure or they're very tachycardic, and you look at with ultrasound and there's fluid in the right upper quadrant or left upper quadrant, technically this is an indication for an emergent exploratory laparotomy, meaning that patient can go straight to the OR, have their abdomen opened, and a source of bleeding can be identified, controlled. That's the book answer. So if you have a test, they should go straight to the OR, but honestly, most surgeons don't always do this. They want more information before opening someone's abdomen. Okay. So you have a 20-year-old male who sustained abdominal injury after being struck in the abdomen with handlebars of his bicycle during a collision with a parked car. The left upper quadrant FAST is positive for free fluid. Which of the following findings would warrant a surgical intervention? Persistent pain, persistent low blood pressure, or a hemoglobin of 8.1? Looks like everyone's saying B. It's nice that people are paying attention. I'm not used to that. Okay. So the answer here is B. With a positive FAST exam, and a hypotensive patient, you would take the patient straight to the OR, like I said, mentioned before in that graph. If they have persistent pain, well, we should treat their pain and reassess. That doesn't necessarily mean they need surgical intervention. And C, although that hemoglobin is low, that's not an low hemoglobin is not an indication for surgery. In this incident, in this scenario, the patient likely has a splenic injury. Spleen is one of the most commonly injured organs of the abdomen. Splenic injuries are important because they're fairly common and they can be deadly, but the majority of splenic injuries can be managed non-operatively. And what's really important is determining the hemodynamic stability of the patient before deciding if you operate. An unstable patient with a positive FAST exam, especially in the left upper quadrant, suggests a splenic injury that's severe and requires a splenectomy or emergent surgical intervention. Okay. So the next part of our primary survey is D for disability. You want to examine the pupils for asymmetry, look for a blown pupil to suggest intracranial injury, which would be a very dilated pupil that's unreactive. Calculate your Glasgow Coma Scale if you haven't, Glasgow Coma Scale score if you haven't already, and look for movement of all extremities. Unfortunately, we have to go over the Glasgow Coma Scale. It's very detailed and it's important. It's very heavily tested. It's also a universal scoring system, and it can help you easily communicate a patient's mental status. Instead of just saying, oh, this patient's trash, this patient's zonked, you can use the GCS to communicate what's going on. So let's review this really quick. The first score is E, the eye-opening response. So if they open their eyes spontaneously, they get a 4. If they only open it to speech, they'll get a 3. If they only open to pain, they'll get a 2. And even if they have no response with eye opening, they still get a 1. So we like to say that even a toaster has a Glasgow Coma scale of 3. Because you get a 1 on each one of these components, even if they're unresponsive. So the next part is the verbal response. If they're completely oriented to person, place, and time, they get a 5. If they're confused, they get a 4. If they're speaking inappropriate words, but they're speaking, they get a 3. If they have incomprehensible sounds that they're producing, they get a 2. If there's no response, they get a 1. And then the next part is the best motor response. 6, they get, they obey commands. If they move to localized pains, meaning pinch someone and they move that arm, that's a 5. If they flex, if they have flexion movement with withdrawal from pain, that's a 4. If there's abnormal flexion, so they're kind of flexed but not in response to pain, that's a 3. If they have abnormal extension, so they're extended or the decerebrate position, that's a 2, and if there's no response, that's a 1. So it's E, V, M, I, verbal motor, 4, 5, 6. Your total, the best score you can get is 15. They're considered comatose if it's less than 8 and you would intubate them, and if they're totally unresponsive, they would get a 3. Okay. So unfortunately, we have to do a question about this. It's okay if you guys get this wrong. It is difficult to do this right on the spot, and there's always, you can use apps, and there's MD Calc online that you can use to calculate this. 39-year-old male is brought in for altered mental status following a motor vehicle collision. Medics report he was not wearing a seatbelt. He has no obvious signs of trauma to his forehead. He opens his eyes. He has obvious signs of trauma to his forehead. He opens his eyes when you pinch his hand. He moans when you ask him questions, and he pulls his hand away when you pinch it. What is his Glasgow Coma Scale? Is it 9 or 8? So he opens his eyes when you pinch his hand. He moans when you ask him questions, and he pulls his hand away when you pinch it. Okay. Looks like we're split between A and C mostly. The correct answer is C. This patient's GCS is 8. He gets a score of 2 for eye opening. He moans when you ask him questions, so he has some response there. He gets a score of 2 for the verbal response. He's not really making like comprehensible sounds, but he's making some sounds. And he gets a score of 4 for the memory exam. He's really localizing to pain. He pulls his hand away when you pinch it. So that total is 8. And like we said before, with GCS of 8 or less, you would intubate that patient. Okay. Finally, we're at the last component of the primary survey, which is E. E stands for exposure and environment. If you haven't already, you should remove all clothing from a trauma patient. You can't really assess someone's injuries if you can't see all of them. So this includes all jewelry, socks, everything. Jewelry creates artifacts in any imaging you do, and you also never know when a finger is going to swell up or some part of the body is going to swell up, and the jewelry can get stuck, and it might not be safe to remove the jewelry later. You also want to cover the patient with warm blankets. After you've exposed them, it's very easy for patients in trauma bay to become hypothermic if they're completely exposed, and especially if they're exsanguinating somewhere. So most trauma surgeons actually keep their trauma bays very, very warm, which is uncomfortable for all of us in all our PPE, but it's the best thing for the patient. And finally, as depicted in this image, you want to log roll the patient to assess for injuries in the back. The way you do that, you roll them to the side and you palpate down their cervical, thoracic, and lumbar spine. And if they're responsive, they can tell you if it hurts or not in the midline area. If they're not responsive, you can at least see if there's any crepiness or step off, suggest that something's broken. Okay. So that was our primary survey. That was a lot, just our primary survey. We've accomplished a lot, but I promise you, as you practice this, you'll be able to get that done in less than 5 minutes. Now we're going to move on to our secondary survey, which consists of the history and a total head-to-toe exam. So a brief exam to see if the patient was unstable and needed intervention. Now we're going to get into details. If your primary survey was significant and your patient's really stable, you can abbreviate the secondary survey while you get the patient to imaging or to the OR or anything like that. So you need to obtain information from your pre-hospital team, any family members or witnesses of the event. You need to get a history of any allergies before you start giving them medications. Especially some people are allergic to opiates, and opiates are one of the most common things we give in a trauma patient. Ask about what medications the patient takes. Specifically, are they on any anticoagulants, which would make them more prone to having bleeding in their brain or anywhere else. Ask any past medical history. Sometimes you never know when someone has hemophilia or something like that can make them prone to bleeding. Also, sometimes we have patients in the United States who are Jehovah's Witnesses who absolutely wouldn't want blood products, so that's something that would be important to figure out right at this moment. If possible, find out when their last meal was. If they're going to the operating room, maybe non-emergently, maybe they have a femur fracture, so it's urgent, but not like they need to be intubated in the emergency department. Maybe anesthesia will intubate them. Then you need to know when their last meal was. And finally, you really need to know the events and the environment of the injury. Specifically, like about head injuries, you need to know if they fell, from how far did they fall, how many steps did they fall off of, did they pass out or lose consciousness, were they vomiting before, are they acting like themselves? If it's an elderly patient with dementia, is this what they always act like? Sometimes it's as simple as asking the patient, what hurts you right now? And then if the patient's awake, they can kind of point out where their injuries are. And make sure you treat your patient's pain appropriately. Often in trauma, we'll use fentanyl if someone has a lot of injuries. It's a great short-acting opioid that won't lower blood pressure. It's fast on, fast off, and it can treat pain pretty well. Also, remember to ask yourself, how did this traumatic injury occur, especially if your patient can't give you history? Did the patient get into a car accident because he or she had a seizure? Did they get into a car accident because they had a heart attack or a stroke? Don't forget to consider all of the medical causes that could have precipitated your trauma. Okay, we can move on. So now we're starting with our head to toe assessment of our patients. First is HEENT, head, eyes, ear, nose, throat. So you examine the scalp, look for any bleeding. Sometimes you can have small arterial bleeding in the scalp, and that needs to be kind of stopped right away because patients can bleed out from an arterial bleed on the scalp. You can use like a figure of 8 or just a quick stitch or just apply pressure, but really if there's an arterial bleed, you should stitch it. Then you can look in the, you want to palpate the scalp, the face, and the jaw, look for any tenderness, look at the pupils again, check again for size and reactivity, examine the ears for hemotympanum. Hemotympanum is often the result of a basilar skull fracture. The upper left picture shows the hemotympanum. Well, I'll show it at the end. You want to look in the nose, look for any septal hematoma or epistaxis, examine the oral cavity for injuries or broken teeth. And finally, if the patient's awake, you can ask them to close their mouth and see if their teeth alignment feels normal. Okay, let's see the pictures. So that is a septal hematoma. It occurs when the submucosal vessels are disrupted and blood accumulates. It requires immediate incision and drainage because you can get really quickly septal necrosis. The bottom picture shows malocclusion of the teeth. You can kind of see it right here. That should suggest a maxillary fracture, which will likely require surgery. And then this is a picture of hemotympana. That's when blood accumulates behind the tympanic membrane, and it's often a result of a basilar skull fracture, although there are other causes of hemotympanum too. Okay, so next you move on to the neck. You assess the patient's C-spine. If they're in a C-collar, have an assistant maintain spinal precautions while you remove the collar, palpate down their neck and see if they're tender anywhere. You want to palpate each cervical spinous process and ask about each one individually. Don't have the patient move when this happens. Make sure you tell them, say yes or no, don't nod your head because patients like to nod instead. And then you would consider cervical spine imaging for if they have any midline tenderness or neurodeficits. Our emergency physicians like to use something called the nexus criteria to determining the need for cervical spine CT. Any neurodeficit, midline tenderness, altered mental status, or level of consciousness, if they're intoxicated, or if there's a distracting injury, meaning they have a large femur fracture that could be distracting them, that would indicate that you need cervical spine imaging. So let's say you'd get a CAT scan of a cervical spine. It shows no fracture, but the patient still has severe midline tenderness. What do you do next? Do you give the patient acetaminophen and take the collar off? Do you take the collar off as long as the patient can walk? Do you keep the collar on and obtain an MRI, or do you get an X-ray? So the question was, the CAT scan shows no fracture, but the patient still has severe midline neck pain. Okay. I think we're running short on time, so the answer is C, keep the collar on and obtain an MRI. CT scans are good at looking at soft tissue and bones, but not all ligaments, not at ligaments, and they can still have a ligamentous injury even with a normal CT scan. So you want to keep the collar on and then an MRI in that instance. Okay, so now we'll move on to the chest. Once again, really touch the patient everywhere, feel everywhere to see what hurts them. Feel the shoulder girdle, look for instability or fractures, check the ribs, look for any tenderness or instability, recheck your lung sounds, listen to their heart, feel the clavicle, look for any step off or fracture. This image shows a seatbelt sign on the chest, which should prompt a more suspicion of an underlying injury. It's that bruising right here where the seatbelt was. Okay, so abdomen, pelvis. You want to examine the abdomen for any bruising. This is again a seatbelt sign across the abdomen. Palpate for tenderness, guarding, or rebound. Avoid rocking the pelvis when you do this. If you're examining the pelvis for stability, you really want to press once inward with both your hands, and then press once on the pubic symphysis. You can use your thenar eminence to do that, but you don't want to rock the pelvis back and forth because that can cause more injury. And if you find blood at the urethra in this exam, you would do a retrograde urethrogram because that suggests that there's a urethral injury. You do not want to put a Foley catheter in that patient. Let's go to the next slide. This is a video on how to correctly check the pelvis for instability.
And of course, technical difficulties. And the video doesn't want to play.
All right, no problem. So, oh, that's all right. So it was on YouTube. So just you can YouTube pelvic instability trauma. Basically, you're not rocking back and forth. You're just pressing inward once, and you feel any give, and then you press once on the pubic symphysis. In reality, it's actually really difficult to assess for pelvic instability. I've assessed it on patients who I know had unstable pelvises, and I couldn't really sometimes tell where the instability was. If you think your patient's hypotensive and they might be bleeding in their pelvis or they're complaining of pain there, you want to put them in a pelvic binder, which you can make a makeshift one by wrapping their pelvis in a bed sheet, or there are specific pelvic binders with straps that really compress the pelvis because you have a lot of major blood vessels internally that could be bleeding. Okay, we can move on. Finally, you want to do an extremity exam. Look at all your extremities, look for strength, sensation, presence of a pulse, range all your joints, palpate for tenderness and deformity. It's very easy to miss that fifth metacarpal fracture when you have a patient that comes in with a traumatic head bleed, but some of these fractures can be unstable or consequential fractures too. So it really is our responsibility to try to identify it. The orthopedic surgeons like to say the number one cause of a missed fracture is lack of radiography. So get your x-rays. Okay, and finally, if you haven't already, you want to roll your patient with assistance and palpate the spinous processes, like I said before. Now, this is often when people will do a rectal exam to check for rectal tone or blood in the rectum. The recent literature has really questioned the necessity of digital rectal exams. You can assess motor function of L5 to S2 if your patient's awake by asking them to flex their gluteal muscles. Doing a rectal exam, more recently we've kind of thought that it puts us at risk. There could be things in there, you'd be surprised people put like razor blades and stuff in the rectum. So you should only really do it if you're highly suspicious of a spinal injury. And so also if your patient's agitated, if you do a rectal exam, that's going to make them more agitated, can make your exam harder. So in some instances you might want to do it, like say if they have gunshot wounds to their abdomen and maybe they have a gunshot wound to the perineum, then you really want to see if there's blood there. Or if they're not moving their legs, and you want to check for rectal tone because you're suspecting a spinal cord injury, then you would definitely do it. Okay, so while we're talking about trauma, it would be remiss not to touch on the role of firearms in trauma. This could obviously be an entire lecture in itself. Just some quick stats I looked up. In the US in 2017, there were 39,773 deaths by firearm. In Bulgaria in 2014, which is the most recent stat, there were 109 deaths. Per 100 persons in the US versus Bulgaria, there are 120 versus 8 firearms. So seems like to me you guys are doing something right over there. But there was a whole on Twitter in 2018 when they said that healthcare workers should, the NRA, the National Rifle Association, said that healthcare workers should stay in their lane when it comes to gun violence, and we're the ones who see a lot of it. So I think it does fall into our jurisdiction. But moving on, this is just a summary of your whole trauma assessment. You do your ABCDE first, airway, breathing, circulation, check for disability, expose the patient, then move on to your secondary survey, get a detailed history, and do a detailed physical exam.